All right. Hello. Those of you who are coming online, I want to welcome you. My name is Dick Krugman. I'm Distinguished Professor of Pediatrics here at the University of Colorado School of Medicine. I've recovered after being Dean of the medical school for 25 years, and now I'm just a professor, which is a really terrific thing to be. We are really delighted that you've joined us at this CU Boulder Conference on World Affairs virtual session. This is the fifth in the series this week and will be the last of this week. We have a terrific panel lined up for you today. Our topic is Our Health Post-Coronavirus, a New Frontier. And our process today is going to be that I will introduce each of our four panelists one at a time. They'll speak for about 7 minutes or so. At the end, we will have a collegial interplay, asking each other questions or making comments about the presentations that we will have all heard. And then we will have time to answer your questions. If any of you have questions, you should submit them to us online in the Q&A area on your Zoom screen. And we will address as many of the questions as we can in the time allotted. At about 3:25, we will begin to wrap up. And that's the plan for today. So even though I can't see whether there are 500 of you or 1,000 of you or even 1 or 2 of you, I once went and gave a talk where there was one other person and he was the second speaker. In spite of the fact that I can't see all of you, we're excited to have you here. Our first speaker will be Margot Witvliet. Margot is an assistant professor at Lamar University in their Beaumont, Texas. She's a social epidemiologist, and we on the panel decided to let her kick off the topic of coronavirus in our future because of all of us, she is one that has experienced it. I will introduce the rest of the panelists when they come to speak, but to just give you a hint, our second speaker will be Irina Petriky, our third speaker will be Peggy Battin, and our fourth speaker will be Shelly Miller. So Margot, I'll turn it over to you.
Hi, thank you. I'm really happy to be here today to be able to speak with everyone and share my experience because for the past 30 days, I've been really sick and I can't say for certain if I had COVID-19 or another illness that impacted my ability to breathe. But that comes because in Texas, we had a lack of adequate testing. And I was tested. I was one of the first people to get a COVID-19 test in Texas. And I happened to be in a very rural community. So the test that I took was not FDA approved. It was an in-house test. So not what some people are able to get today. What I do know is that I had a number of symptoms. I had excruciating chest pain. It felt like an elephant was sitting on my chest. I had a very difficult time breathing, and I had diarrhea. I had pain in my abdomen. I had blood in my urine. I had a dry cough. The only thing what I didn't have was an extremely high fever. I even had chills where I was shaking uncontrollably. So was it COVID-19? It seems that way, but without a test a good test, it's hard to know for certain. I had a good team of doctors. Of my doctors, my lung doctor thought that it was perhaps another illness that was impacting my rib cage from being able to expand and contract. But my other doctors on the team were convinced that it was COVID-19. I took a number of tests. I was in and out of the ER. I took a CT scan, EKGs, my urine work was done. I did a flu test and everything came back normal. And the COVID-19 test, I had to wait on the outcome for that. So I also had a very unique opportunity with the fact that I was in Amsterdam when COVID-19 took place, when it really started to become a global health problem. I was in Amsterdam. I had visited Paris. I had visited Belgium. I remember when I was in Paris, I was at the Eiffel Tower and a group of Chinese tourists were there. Nobody wanted to take their picture. It was a really big discrimination problem amongst Chinese tourists in Paris. They asked me to take their picture with their cell phone. I did. And I know that when I was there in Europe, people had started panic buying already. They were buying all the soaps and products, what you see Americans doing now. And at the same time, when Europeans were starting to panic and were awakened to the COVID issue, in America, we weren't. Our news was about, for example, the death of Kobe Bryant. We were still saying in the media that the risk to Americans remains low, but there was no data to be able to back those claims up. That was just what was told to the American people. And so Americans were still sleeping. And so as COVID traveled across the globe, I prepared to get on the plane to come back to Houston. And for me, this all reminds me of a sci-fi film where the zombies are walking around, like with Will Smith in I Am Legend. And COVID-19, it's an invisible virus, so we can't see it. But if it was life-size and we could see it, I don't know if I would have left my house that day to take myself and my two children and my family on an airplane ride mixed with all of these people. But I did that, and we made it to Houston. At the border, nothing was asked of us, really. The plane was pretty much empty. And the borders, even though in the media that it was said that the borders were closed, the borders were clearly open. And people were walking in. Nobody was using gloves or protective gear as far as the workers, the TSA workers there. So I can just imagine how many people got into the borders and weren't checked. The only thing that was asked of me was when I was in Amsterdam was had I traveled to China in the past 2 weeks, but with a simple no, they let me right on board. And so once I got in and I saw that there was nobody on the plane and that it was just a dead zone, an international airport, I knew immediately that this was going to have a severe impact on the economy. But this was not being spoken about in our media, not yet. And then about 10 days later is when I first started experiencing my symptoms, and when I landed in the ER for the first time. And so what COVID-19, what I want to leave with you guys is what this pandemic has really shown us is something what health disparity researchers have been speaking about for decades, that the disease model that we use is not the right way to go, because when something like this happens, there's so many people impacted. And I am lucky in that I had good healthcare insurance. I'm lucky that I'm a professor, so all of my classes were put online and I don't have to go to work, because that was one of the things that my doctor asked me was, can you stay home? And I said, yes, I could. But there are so many people, so many Americans out there who are not insured or underinsured. So if they're having symptoms like what I had, they're going to think twice about whether or not they're going to go to an ER. And this was some of the worst pain I've ever experienced in my life. And I've had two children naturally, and I'm normally a healthy person. So also the medicine, what I was given was not covered under my insurance. I was given the medicine that you're hearing being talked about in the media, the Z-Pak and the anti-inflammation for medicine for arthritis. And I can say that that really helped, I think, save my life. And I'm thinking about all the essential workers and the women, especially because women are typically our essential workers, our housekeepers, our nurses, and all of their children are home. So they're out here trying to save our lives, but their children are left behind. And also the prison population as well, who can't social distance, and the guards who come back to our communities are impacting us all. So this is something that's going to be a huge problem, not just now, but also the ramifications afterwards, especially for mental health thereafter. So I think that I want to leave you guys with that. It's not just about getting a vaccine for COVID-19. It's about getting the right vaccine for America with how we treat our illness model that we currently use. It needs to be totally revamped. Thank you.
Thank you, Margot. There was one question online, and you can give a quick answer to it. They asked, what day did you come back from Europe?
I came back on the 2nd of March.
Okay, thanks very much.
Mm-hmm.
We're following Margot with Irina Petriky. Irina is a professor of medicine and pulmonologist and head of critical care at National Jewish Health here in Denver and at the University of Colorado School of Medicine. She has been up close and personal with this particular issue, and we thought we should follow Margot's story with a clinical perspective. Irina.
Thank you, Dick. And I also appreciate Margaret's introduction of what this disease can look like. And I'm really happy to see that you have recovered well from it. And I'm sorry you had to go through the anxiety of not knowing what you had. As you all know, the COVID-19 disease is the result of inhaling a very small virus, which is a coronavirus type, and very small particle size, as Margot alluded to. And it is invisible, and it first impacts our breathing system. It is a respiratory disease after all, but eventually it can lead to multi-organ systemic condition that could result even in death, if not prolonged disability. So it started in China, as you all know. It was transmitted very likely from bat family of coronaviruses, and it jumped to humans. And it spread so rapidly, and in a way took a lot of people by surprise, perhaps because we were so lucky and smart in containing other respiratory viruses, other epidemics that involved respiratory viruses, including sort of cousins of SARS-CoV-2, which is what this virus is called scientifically. And I think we were able to control that in the past, not only because we are smart about it, but also because the incubation period and the early phase of transmission for coronavirus COVID-19 causing disease is very silent, and it's much more difficult to tell who is sick and who's not sick, and who can be isolated and who cannot be isolated. So we had to deal with these super spreader events early in the epidemic that were superimposed on globalization of travel and contact among people. So what I mean by super spreader is someone who is otherwise looking healthy. They were going to the gym or going to those field stadiums at soccer games, and really from one individual spread it out to a multitude of other individuals that then took it and exponentially carried the virus to their community, to their families, etc. I think there was also a little bit of a complacency in how severe the disease can become. And I remember hearing from the media early on how 80% of people maybe have just a mild disease. This is just the flu. And we quickly learned that that is not the case, that it's the rapidity with which it gets transmitted to individuals and how sick these individuals can become can paralyze our unprepared, sometimes medical healthcare system, and then again reverberate on the way we treat other conditions. What I mean by that is that cancer doesn't stop now that coronavirus 19 is on the street. Regular pneumonias don't disappear. Women still have complications after childbirth, etc., etc. So you add on a medical system that's optimized to deal with a certain size of morbidity. You add this immense wave of cases, and you can see how it can really paralyze the system. Furthermore, our healthcare providers are getting sick, and that amplifies again our ability to take care of those that need the most care right now. So I would also like to touch upon who is at risk for getting severe disease and getting hospitalized with coronavirus 19, which again, it's also known as SARS-CoV-2. We are learning now, both from the Chinese epidemic, wave of epidemics, as well as our Italian colleagues, that definitely smoking and age are risk factors. We're now trying to understand if vaping also predisposes the younger population who is using more of the vaping products, whether they are also more at risk for more severe manifestations of COVID-19. It seems that males, and especially those with diabetes or what's called syndrome X, which is a combination of glucose intolerance or early diabetes or diabetes plus obesity plus hypercholesterolemia, also seem to be predominantly filling our intensive care units especially. And we're learning from the epidemics or the outbreaks in, I should say, in Chicago and Louisiana, that underrepresented minorities and perhaps those who don't have access as easy access to healthcare seem to be predominantly affected out of proportion to their presence in a population. So clearly we are learning every day something new about how this virus affects us and how to prepare for it and what to pay attention to. I would like to also mention, if I have time, I'm going to look for 1 minute. Half minute. I wanted to mention that what seems to be working the best right now is actually this personal isolation and maintaining personal space that prevents the inhalation of these small particles into someone else's respiratory tract. And we see that pretty loud and clear, that societies and communities who have respected and instituted these very harsh measures from an economic standpoint, but very effective in lowering the peak of the curve and allowing our doctors, nurses, and first responders to deal with the number of patients, I think are more impactful than any experimental drug at this point. Thank you.
Thanks very much, Irina. Peggy Battin has disappeared from my screen. I don't know whether that means she's here. Are you here, Peggy? Well, we're going to do something on the fly. Shelly, are you ready?
Sure, I can go ahead and speak.
Just hold it. Let me introduce you. Shelly Miller is a professor of mechanical engineering, and I think having her speak at this point is actually useful because we've just been hearing about the small nature of this virus and how difficult it is to protect ourselves from it. Shelly's background is in air pollution of all forms and helping make our air safer for us. So she is a professor, as I said, of mechanical engineering at CU Boulder. And I'm going to turn it over to her for the next 7 minutes.
Great, thanks. I wanted to start with what?
Did you say 8 minutes?
I'm good. I'll start. I wanted to start with an explanation of how aerosols are transmitted through the air phase of, and so I wanted to go to this diagram because I think it's a really nice explanation. If you're an infected person and you breathe or talk or sing or cough, you generate a cloud of particles of all different sizes. And the large particles drop to the floor or surfaces that can then be picked up and transmitted through your hands. We also know that there are very fine aerosol that is carried long distances and can stay aloft for hours. And if you're in the cloud, which is, you know, something around 5-7 feet, you can inhale the aerosol directly. If you are farther away and the aerosols are fine enough, or particles, airborne particles, the same as aerosols, are transmitted long distances, you still can inhale the particle. This is why physical distancing is very important, especially when you're outside. We have lots of people outside on the trails here in Colorado. Making sure you're staying away from people is key to arresting your own possible inhalation exposure. It's pretty clear the CDC has been communicating that the airborne transmission route is possible and very likely. WHO has yet to come out with a strong enough recommendation on airborne transmission. We've had a lot of studies coming out every day showing that the viral RNA can be detected in the air. It's been detected in hospitals, it's been detected in department stores. We have seen it in particularly a situation in Nebraska where they were housing 13 passengers from a cruise ship. And here they detected 63% air samples were positive by PCR. What was interesting from that study is a personal sampling happened where the workers were wearing small air samplers and their levels of RNA airborne copies were much higher by a factor of 3 to 4 than just hallway air samples. There's also really strong, compelling evidence to show that transmission is happening in crowded, poorly ventilated spaces, of which many of the environments that we inhabit are poorly ventilated. You know, think of restaurants, or sometimes even our classrooms are not getting enough fresh outside air to dilute any airborne particles that are being generated by the occupants. So we've seen lots of clusters happen, for example, in Washington State, where almost the whole choir got sick by singing in the church. There was a big cluster outbreak in an air-conditioned restaurant in China. A big ski areas have been experiencing lots of transmission due to crowded, poorly ventilated spaces. So that leads me to the last point, which is that the virus viability depends on the RH. Most viruses tend to decay in air when the humidity goes up, and they do really like dry air. Which is typical for Colorado. What we need to be doing when we go forward from this pandemic is as the pandemic comes and goes while we're waiting for our adequate testing and our viruses, is that we need to continue to wear masks, even if it's a precautionary a possibility that it's going to reduce your exposure slightly, but still it's worth doing. We need to consider increasing ventilation rates in our buildings and with outside air, no recirculation of air. This costs a lot of energy and it's difficult to do in many buildings. If you can't do it in your building, then you should be using air cleaning and disinfection devices. We have technology that's an air filtration that can help, and also ultraviolet radiation can help. UV germicidal light is a great technique for crowded, poorly ventilated spaces. So we need to be moving towards these engineering controls in the future to make sure our indoor environments are safe during a pandemic. We also need to minimize the number of people sharing the same indoor space so that we reduce viral loading and unsuspected transmission. And that's all I wanted to say at this point.
Terrific. Thank you, Shelly. There are a couple of questions. There were a couple of questions that came up while you were speaking, one of which is, how is this similar? Well, let's come back to that later, because I understand we have Peggy back.
Yeah,
she is on the phone. Peggy Battin is Distinguished Professor of Philosophy.
I'll hang up once it's working.
Medical ethics and an adjunct professor of internal medicine at the University of Utah. And I'm going to turn the next 7 or 8 minutes over to her, and then we'll get to interchange and questions. Peggy?
Hi, I'm talking from Salt Lake. What happened to my video, I don't know, but I'm very happy to be here with you in principle in Boulder. So I'd like to I have 3 things that I'd like to talk about from the point of view of looking backwards at what's been going on after this is over. And of course, one obvious one is, how did we get so far behind? How can we improve testing? And how can we learn to do testing that's non-invasive? And in fact, could we ever discover how to do remote testing? Think about the parallel with surveillance by temperature. You used to have to put your hand on somebody's forehead or a device on somebody's forehead or somewhere, but now we can scan it from a distance. Could we ever do that with testing for viruses or other transmissible infectious disease? A second thing we ought to learn, I think, is that we should not think about just about this particular coronavirus or another coronavirus or similarly aggressive virus that might come up, can be expected to come up in the future, but to think about controlling other transmissible infectious disease with what we've learned in working on this one. There are lots of bad things out there. Tuberculosis is one of them. HIV, of course, is one of them. There are many lesser known diseases that are prevalent, however, and if we can use the same technologies that we're using, that we've been developing, that would be a good thing. But the thing I'd like most to talk about here is about what triage entails. As you know, there is consideration of when we will be unable to meet demand for ventilator or other support. That might include medications, that might include other kinds of things to arrest the course of the disease. We have to say to somebody, we are sorry, but we do not have a ventilator for you. And that's just the way it is. So the question is, what do we owe, if anything, to people who get the short end of the triage stick? Now, for some people, the disease progression is so rapid that ventilatory support doesn't make much sense anyway. And there are other people who will be likely to recover without it, as for instance, Margot apparently has done. This is just wonderful when it happens. But we're talking about people in the most serious triage situations whose chance of survival would be dramatically increased with ventilatory support, and who aren't going to get it because we haven't succeeded in providing enough for it to meet the demand. So here are 4 things that I think we owe people. We almost never talk about what we owe people who get the short end of the stick, but this is important. And after all, it could be you. It could be me. So first, right to information. I think You deserve an honest account of why you're not being given access to treatment. You deserve to have your own case considered on its merits. You need to be able to know, if you want, what the overall prognostic information is for you if you don't get a ventilator or whatever else you might need. And you need to know accurate prognostic information about the after effects of sustained treatment or mechanical ventilation if you did get it, what the physical sequelae is, what the cognitive impairment might be, if any. So you need as much information as you want. Second, I think, of these 4 points are rights to personal choice. So being triaged out shouldn't rob you of choice. You can express consent to being excluded or protest it. You should have the right to try, within reason, alternative and unproven therapies. The hydroxychloroquine and azithromycin combination that's been tested in France is being tested in places here. Or, I don't know, intravenous high-dose vitamin C or zinc. None of those have been shown to work. But it seems to me this is a situation in which the right to try, as has been recognized in many ways, should be open to you. Safety and efficacy may not be established, but in this case, you're facing an increased risk of death in any case. And as far as personal choice goes, I think it also includes the right to try to enroll in or refuse to participate in clinical trials, and especially to know whether any treatment you're being offered is really part of research or whether being in the non-treatment arm is equivalent to being triaged out. That is, if being triaged out is actually part of a study. Third, this might be the most, well, all of these are important, but rights to communication. The rights to visit from family members, if they can come in protective clothing, or the right to have expertise put into voice or video hookups with family members. Same, being able to say goodbye. Remember, these are the people who, because they're not getting access to further therapy, are more likely to die. The right to say goodbye, the chance to say goodbye, to make amends, to engage in that kind of communication. That grief counselors will tell you that this is important not only for patients, but for their survivors as well. It also might include the right to visits in person or by voice or video from your own religious advisor, not just the hospital chaplain. And of course, hospital chaplains can be enormously constructive and helpful, but your own religious advisor may be somebody you especially want to be in contact with. From your personal attorney, maybe you want to revise your will. From coworkers about how to continue projects that are important to you if you die, and significant others. You might even want to be able to see your pet, right? That's not as silly as it thinks, right? Pets can be enormously important to people as sources of solace, and to know that somebody will be taking care of that.
1
party.
minute, Nikki.
I'm sorry, what?
1 minute.
1 minute. So the last one in 1 minute, the right to a humane death. There's what counts as humane end-of-life care. There's palliative care, and you need to be able to have full information about what this involves, whether it would be reliably available to you. In some states, there's legal medical aid in dying. These states include 22% of the U.S. population. If that's something you'd want full information, waived waiting periods, waived multiple assessments of terminality, and the right to receive expert assistance in dying. Now, it's not clear that people will necessarily want that, but of the things that should be made available to you under the general category of a humane death, this is where your choice counts the most. Because after all, even if you're denied the most effective form of care, you still want care. And we should all remember that whether in this situation or some future calamity, we owe it to you and also to our own future selves to think through how, in cases of egregious scarcity that cannot be resolved, but we owe those who are counted out. Thanks.
Thank you very much. Okay, panel. I'm going to see if any of you on the panel have questions for anyone else on the panel, or given the conversation we've had so far, want to follow up. Margot, you just unmuted yourself. Does that mean you'd like to talk?
I will. I just unmuted it because I knew it was time to start chatting. But what I really liked what Peggy had to say. When I was admitted to the ER, they blocked me from seeing my family, and I went into the ER because of extreme respiratory distress. So having that right to be able to have that comfort there would have been helpful to me. And so I find that very nice what she spoke about. And I also liked Shelly's talk about the air particles and the pollution, because being down here in Southeast Texas, where it's heavily polluted, I am literally trapped inside of my house because the air is so heavy for me to go outside. That's when it hurts most for me to breathe. So basically what I did, you can, on my YouTube channel, which will be coming up shortly, I chronicled my experience with COVID, or with my difficulty breathing, and my time from coming back to the States. And a lot of this stuff, what they speak about, is covered because it's really true what they have to say.
Thanks.
If I could add, a recent study just came out showing that the difficulties with illness from coronavirus is worse in highly polluted cities, highly polluted air pollution cities.
Yeah, I could comment a little bit on that, and that adds to these risk factors that I mentioned, including smoking or vaping, because we depend on our respiratory epithelium, and which is the lining of our lungs, and also on the inflammatory response and defense, innate immune defense responses of our lungs to annihilate, to neutralize the attack of the virus. And if these defense mechanisms that we are born with, if they are weakened because they're busy trying to detoxify other respiratory irritants, such as pollutions, which consists of particulate matter and a lot of oxidative stress, smoking the same, vaping the same, if they are busy and exhausted trying to clean up the lungs from those, they have very little bandwidth to deal with this new tremendous attack by the virus.
So one of the things I had a flashback to with this whole conversation was I happened to be in New York City in 1949 as a 6-year-old when my father went off to deal with the smallpox epidemic in New York. And the smallpox virus, I remember his recounting it, was transmitted within the hospital from the 2nd floor to the 5th floor and infected other people through the air ducts. Shelly, what are we doing to protect hospitals and indoor environments from the transmission of this or other viruses? And there was a question, is this the same as or worse than measles was when we had measles, or smallpox, or something else?
Yeah, so the classic airborne diseases are measles and tuberculosis. And we think that the measles, I'll start with measles. Measles is more infectious. We know the infectious dose and how it can be transmitted, and one person can affect tens of people, compared to what we currently think for COVID-2, which is just a 2 or 3 people, except if you're a super spreader. If you're a super spreader, you're going to be generating 6,000 particles in 10 minutes, and you will infect many more people. So it just depends. Currently, we have not had any reports of transmission via the ducts in buildings. So we don't know whether that is a potential. What we recommend is that you provide 100% outside air. You do not recirculate the air in a building. This is a pandemic mode operation. And you increase your ventilation rate as much as possible. For health, we recommend 25 liters per second per person, which is a lot of ventilation. Current buildings are maybe 3 to 4 liters per second per person. And if you're at home, you really should be opening your windows.
So what happens when you're in a heavily polluted area and opening your windows means letting in a lot of air pollution?
Yes, so that is a real difficulty in many urban areas, and unfortunately, the only solution to that is, to potentially purchase a pretty expensive air cleaner that you can use in your home. I just upgraded my air cleaner, but not everybody has $300 to $500 to buy an air cleaner to keep their space clean. So that's really the only options we have right now.
I think there is a silver lining in some of the communities that have instituted this stay at home as much as possible, minimize travel, etc., because we do see a dramatic decrease in the levels of pollution and in multiple countries and communities, and perhaps that at least temporarily can provide some peace of mind.
Okay.
I have to say I'm happy to be back.
Thank you. Welcome back.
I don't know what happened to my internet, but here I am. In the community that I live in, which is a lot like Boulder geographically, I live in Salt Lake City, the air is cleaner perceptibly than we have seen in years. Well, ever. It's remarkable.
Yeah.
So it gives us, if we're thinking backward to what we've learned that we don't have to live with dirty air.
Right.
How can we keep that in mind?
Peggy, one of the questions that has come in relates to the health professionals who are working with these patients and who are putting themselves at risk, and how some have been speaking out about their lack of supplies and getting fired for that. What are some of the issues around the frontline workers and those of us who are contributing by turning into talking heads on computers?
Well, here we are. So there are stories about people getting fired for speaking out. What we don't know, and these stories rarely make the news, is how many people have spoken out and been thanked and have had their suggestions and recommendations and concerns acted on by sensitive and informed healthcare systems. Mm-hmm. So we need to hear a few more of those stories as well. Right. There's no question, but this is an enormous strain for hospital systems generally. It's a financial strain, it's a capacity strain, it's a let's rethink everything we do kind of strain. Many have canceled all elective procedures, for instance. That's normally a major source of income for a healthcare system. It's they're having to rig up special spaces to treat COVID patients. They have had to rethink their prioritization. Many, for instance, are drawing up triage policies that are amazingly painful to think about. Here's a person we could help and can't. Yeah. We just can't help everybody. We read the stories from Italy, where that occurred in quite large scale. We have to think about, why are we so far behind when there is such a vivid lesson, just in front of us? And why can't, I'd like to repeat what Margot said earlier. It's not just, why can't we get the right vaccine for this virus, but why can't we get the right vaccine for America, right? We need to fix our healthcare system in many ways to really respond adequately. As for specific healthcare workers, this is a whole range of people. We have accounts of the behavior of healthcare workers in plague times, from ancient to medieval times. Some run away, some stay, some enter into help. Those are the really remarkable ones. It's hard to generalize about people, but we should treat them all better than we do.
Okay. Some conversations, some questions have come around masks. How effective are masks? Shelly, Irina, you're both dealing with these every day, one way or the other.
I would like for Shelly to address the effectiveness relative to the particle size, and then I can address the shortage and practical implementation of the ideal.
Perfect.
Yeah. So many of my colleagues have been measuring the effectiveness of different materials for filtering the particles out. It's pretty easy to filter out the large droplets. The fine aerosol, the very small particles, are much more difficult. Typically, if you have multiple layers, though, that is how a filter is, a real air cleaner is built, is a layered approach where you have filter after filter, fibers layered. So if you can have something that's a little bit more layered, that is an effective way. The main concern is the fit around your face. If you don't have it pretty tight, or at least, close to your face, the airflow can go around the mask, and then that's how the particles really leave the mask and go out into the environment, or come in your mask and get into your respiratory system. So, I have a cloth mask that's 3 layers, and I make sure it's really tight against my face, and I'm really happy that I go out and wear that. I went to Target last week after not going out for a while, and I was dismayed that none of the workers had been provided with healthcare anything. The checker had said she had to buy her own mask, and there were college students roaming the halls, including one of my students, without a face mask, and it was kind of distressing to me.
Should we be washing our face in addition to our hands when we take the mask off?
You should not touch the mask once you take it off. You should take it off with the ear things and put it aside for 5 days and let it sit. Or wash it immediately.
Bag maybe with it. So this is
there she is.
And then you have to not touch the outside of the mask, and then place it in either a paper bag or an area where you let it air, and you can reuse it after a few days, like Margot said. I think this topic is quite dear to me, and I'm passionate about it because it caused me multiple sleepless nights. So as Dr. Krugman alluded to, I'm a division chief, so I'm responsible for at least 90 pulmonary and critical care doctors and nurses that go in day and night to take care of patients, and they see more and more COVID-19 disease patients. And to not be able to protect our colleagues and our workforce, it is heartbreaking. And to not be able to do that in the United States of America today, it is just shocking. And I still don't know exactly why, We have been fortunate at National Jewish to go into a contingency plan rather than a crisis plan, which is the worst case scenario where we have to come up with inventive ideas to replace the best types of masks for our healthcare providers. But people are quite resourceful, and the public and other private institutions and donors have rallied together to help the healthcare workers during this crisis. It is, in my opinion, it is crucial to prevent that by having the right PPEs or personal protective equipment is the only way to prevent this disease from spreading to our healthcare workers. And the public, in my opinion, at this stage of community transmission, like our governor suggested, strongly encouraged, should be wearing masks when in public, either the surgical type or, as Shelly recommended, the cloth masks that are of appropriate material and filtration. Finally, I would like to mention about wearing masks when exercising. And although we are awaiting properly conducted studies for that, the current evidence is that most people do go outside now, and if they're healthy, to exercise and shake off some of this staying at home for too long, and exercise, especially here in Colorado. And our trails and parks are becoming quite crowded. And perhaps the 6 feet distance recommendation is perhaps inadequate for those who exercise, especially those who exercise heavily, because the respiratory droplets are likely to first come from deeper into the lungs and be more numerous, and also spread at a higher velocity and higher distance. So I am strongly encouraging those who exercise outside to, in heavily or even just public areas, to use a mask when they do it, even though it's a bit harder to breathe.
I agree.
Good. So a question for all of you to think about and answer, and we'll start. I'll start with anybody who'll answer it. The question is, what do we think this experience has taught this country, or has shown this country? Actually being taught and learning are separate things. But what have we learned about our healthcare system, how we're organized, how we deliver it, and how we deal with public health issues that might change going forward? Because our focus here is really for after this. What are we going to take away from this that will position us in a better place in the future? Who wants to start?
Well, I'll start with a very quick remark, and that is one thing we've learned is the importance of global communication and cooperation. Now, many countries share information about, not all of them do. An organization like WHO needs much more support and funding and I think leverage. But we have to realize that, as we say, we're all in this together. Right? These are global issues. And they're global issues about supply chains and testing and border controls and lots of stuff like that. But essentially, it's this bigger picture of cooperation that is so critical.
Okay. Anyone else?
I'd like to say that something that COVID-19 has illustrated to us is that diseases that carry with person to person can travel easily across the globe. We see that it started in China and it made its way over to American soil rather quickly and is impacting us on a huge level. And we are only as healthy as our weakest links. There's going to be a lot of populations that are going to be extremely devastated from COVID-19. Native American population, especially, which is already small. A lot of poor people, African Americans, we see are dying in huge proportions. And this is something that, again, I've already stated, but public health professionals have been saying this for decades. So moving forward, the research is there. Comparative researchers have done the work. So it's up to politicians and the American people who put the politicians in power to require that we fix this, because it is fixable. We have the money for it. We waste a lot of money with corruption in our healthcare systems. That's a huge problem in our healthcare system that we need to start talking about if we plan to move forward. We can't just go back to business as usual in 6 to 18 months from now.
Great points. I would like to add a few thoughts about it. I really like this question. I think, especially if we're going to come quickly with an effective vaccine, I'm hoping that we would learn about the importance of prevention of communicable diseases and the importance of vaccination. And that is just an example of how we as a Western society, in which the individual typically has a lot of say in how we do business. In some instances, such as healthcare, perhaps the societal interests and values may have to be taken more seriously and perhaps supersede in some instances those of the individual. And I know this is quite heresy, what I'm saying, but this example of measures implemented that are working to prevent deaths are taken at the society level. So we have to think about it from all perspectives. I am also quite impressed and inspired by how bringing down the walls of communication and providing care that have been increased in the past by a lot of bureaucracy, by a lot of, again, unnecessary hurdles to the spread of information, to how quickly you can publish a paper that is peer-reviewed. We're seeing now that this is done with light speed, effectiveness, and we're learning from our Italian friends, from our Chinese friends and colleagues, they are now friends, so quickly, and we don't have to wait for a 5-year peer review process to really implement very quickly, do clinical trials very quickly, and learn from each other, distribute potentially effective therapies much faster. And again, this collaboration, I think we can learn a lot what worked and hopefully sustain it.
Mm-hmm. I think that's a good point. I just want to throw this in, not only on the research level, what you speak about, but also in the day-to-day level. We are seeing in America that we can work from home and things still run. When before, if you would hear studies out of Scandinavia saying, well, we're going to a 4-day work week, and we'll say, yeah, that'll never work for America, that never works for economy. And we're seeing that we are being very effective with a lot of working from home type things. So America doesn't have to continue to stay in this type of cutthroat society of what we're used to, this work society. Work can be done also at home, just like research papers, peer reviewed, can go way faster. So we're starting to see things that we can do, what we thought that we couldn't, because as Americans, that's one thing that we're good at, is making things work with what we have.
I would just observe, and I agree with that. It's remarkable the last 3.5 weeks, how much I think I've gotten done. But I'm a septuagenarian with my wife, and we do not have the 4 sons that we had around the house many years ago here trying to do school as well. And I think part of what we need to balance, and maybe this is something to ask about going forward, how do we disengage from this? How do we, once it is safer, because it may never be safe, to stop the stay-at-home process, how do we actually re-engage? Is there a process there? Can you go out and go to places? Do we think restaurants will be 50% as big as they used to be and try to make a living? How's this going to work? Anybody have thoughts? Oops.
Oops.
Well,
You can just walk right out into the middle of this question, but everybody viewing will have thoughts about it too, because we're all in the same place. Everybody who's wired into us now. And as you say, we don't know how many people are out there, but you're there. Maybe they could leave little notes on the chat about what they think.
Well, we're about, it's right now, 3 o'clock, and there are 17 questions here.
Okay.
And we have 25 minutes left before I wrap up.
Let's just say that this is the biggest question among the biggest questions of all. We hope that we can learn that we're more able to be alone than we used to be, that we can communicate at a dinner. You can have a Zoom dinner with somebody in a distant city. They're eating your dinner, their dinner, and you're eating yours, and you're each drinking your glass of wine. Those are pleasant, right?
Yep.
We don't need to come to conferences. We can do that. We can learn a lot from this.
All right, panel, I am going to ratchet down the now 19 questions that I see, and you have the opportunity to be as stunningly succinct as you can be. This is rapid fire questions. Number one, what's the status of airborne particles when you're outside? Shelly?
You're still generating just as much as when you're inside. The only difference is it's better dilution, meaning the air, you have a much larger volume that will dilute your particles, but you have a big plume of particles that other people can walk through and you can eject it right at them. I would wear a mask.
Okay. What does the panel think about the elimination, and Irina, I'll start this one with you, the elimination of all of the unnecessary procedures, the elective procedures that were going on. The questioner says, I wonder how the panelists feel about not only the waste of medical supplies, but more importantly, exposing babies to prolonged exposure risk in a medical setting. How do we, and that goes, but I went too far there. This question actually got into why should we be circumcising healthy little boys in hospital?
I can address not specifically that part of the question, but in general, this question. So there is absolutely no doubt that at the stage of the pandemic and at the local level, at a stage when there is increased spreading, the cancellation and I should say postponement of elective procedures was a smart thing to do. For all those reasons that the person who asked the question stated, saving PPEs, lowering the risk of exposure of both the healthcare workers as well as the patients. And actually in Colorado, the governor did issue a rule that those procedures should not be performed for the duration of this height of the pandemic.
Okay. Margot, there was a question specifically for you. Have you had any after effects with your recovery?
I'm not fully recovered yet. So I'm still on oxygen when it gets too much. I was happy yesterday that I could walk to the top of my street and back for the first time. So
it's good you're at sea level. If you were up here with the rest of us, it'll be harder.
Yeah, I bet, but I'm in a very polluted community. Yeah, so I do have that.
So I have a question for Margot about your health experience. it is now possible to take antibody tests. Would you be likely to do that to determine whether
Oh,
you now immune?
absolutely, absolutely. When it becomes possible here in my community, that's something that I absolutely would do, and I'll probably, like what I do most time, video blog about it and put it up to share the knowledge with others. One of my experiences is going into a hospital and that there was nobody there. That's really weird to see since COVID. It's completely empty.
Yeah. It's also partly an answer to the question about what we do looking back. Presumably we will eventually be able to test people on a larger scale to see who is now presumably immune. And then perhaps those people can play roles in high contact areas.
I've read some reports that there's some data that shows that people who are O positive or with that type of blood type seem to be immune to COVID-19. I don't know how accurate that is. Perhaps the other panelist knows. But what I do know is that I did come into contact with people with that blood type. And for example, my mom has that blood type and she didn't get ill.
So I would like to comment a little bit on this question. And first of all, this level of immunoglobulin G, which is one of the antibodies against the virus, there are people who mount a very good response to the virus, a large secretion of these proteins that neutralize the virus. And there's now clinical trials and sometimes even clinical use, outside trials of serum or blood from patients who have recovered, who do show high levels of this protein. They go into a machine that isolates and purifies these antibody proteins, and then they are given to those who are severely ill and cannot mount that response to hopefully improve their ability to survive and fight the virus. The results of those trials are not known. But this does speak to sort of an individual chance of responding. There's so much about the biology that we don't know. Recently, I think today I read in the lay press that there may be a recommendation for people to have a card with what their IgG antibody levels are after the virus. So they would be considered, check that box. You're not infectious, you're not at risk for getting the disease again, you're free to roam around your community. So I don't know if this will be part of that recovery plan that Dr. Krugman asked before, whether we are going to start opening our society to those who are now more immune to it and have those that haven't been affected be more protected or more isolated. That remains to be seen. And finally, to address the long-term consequences of the COVID-19 illness, we still don't know, but there are reports from China that perhaps those who have been severely affected as far as their respiratory system. And again, I want to mention that lungs are the first to be affected and the more commonly affected, but not the only organs affected. We see a large number of people who have heart disease. Even after they recover the lung, the virus attacks their hearts. So we are actually going to actively examine these patients at the place where I work to look for these long-term consequences. So to go back, early reports from China may indicate that some people with extensive lung disease may develop a fibrotic response to repair. So fibrosis is a way you repair a wound. So we'll have to really look carefully. Many people may just recover completely, many may have some consequences. It's too early to tell.
Okay. Another question that's here is, what does it look like for humankind after all this death for the living that have not been able to grieve properly or see their loved ones in the hospital who are dying? Peggy, you want to take a crack at that?
Well, I think one thing we need to think about is rituals of group mourning. So we often take mourning to be a private experience. And of course, it is a private experience. You've lost somebody that you truly cared about. But to remember that this is a world in which lots of people are losing people nearest and dearest to them. That you're not alone in that sense of anguish, that sense of unfairness, that sense of resentment about things that did or didn't happen that should have happened, and that sense of political frustration. All of that is something that we all share, right? And that, it seems to me, is probably the most powerful way to try to overcome the absolute heartbreak of losing someone. The heartbreak doesn't go away, and there's no reason in grief why grief should end. It's the what we call complicated grief, where there's something that's unresolved, or some tension that never got fixed, some apology that never got made, some acknowledgement. That stuff is what makes grief more difficult and more painful and more problematic in the long run. But just to recognize that all of us were hit virtually without warning by something we couldn't do much of anything about.
Yeah. Shelly, what should at-risk people be doing in terms of their homes? Should they stay away from others who are going out to take precautions? In other words, I have an at-risk person in my house. I'm doing the shopping. She is not. Should she stay away from me? Should we self-isolate or wear a mask in the house? Should all the windows be open? That's a single run-on question from one of our folks.
Yeah, really. And I saw there were a lot of questions on masks as well. Just looking through my papers, we still don't have a good recommendation, although surgical masks appear to be, really effective. And they're really, you want to think about also that the best use of a mask is to make sure that you don't spread the disease into the community. That's the best use of a mask. If you're unsure whether you are carrying and you're in your home with somebody who is sensitive, you wearing a mask will protect them. On the other hand, if you've been living together for quite a long time, you probably either one of you should have already gotten it. So I would say, increasing the relative humidity in your room, in your house, if you can, opening your windows, making sure that you're not relying on toxic chemicals to clean your space, or don't use weird toxic chemicals to out of fear because you're trying to kill the virus. There's lots of toxic chemicals out there that will make you feel worse. But I think in the future, where we need to be moving is a better understanding of how we ventilate our buildings and how we might rapidly respond to a situation like this, where we can easily switch our ventilation systems and our filtration systems and the way we handle our air in our buildings to a method that's much more protective than what we do now. And right now we're expending tons of energy to heat and ventilate our buildings, and yet we're doing a pretty poor job of it when it comes to infectious disease control.
I would also like to comment on the safety of going back to your family once you are exposed or carrying or you are diseased. So the recommendations for that change quite rapidly, and most of the wisdom comes from very small studies that in the past would not even be published, like 20 people that we swabbed every day, and we saw after how many days their swab becomes negative. And again, the testing that we have measures particles, and shedding of particles doesn't necessarily measure how alive and replicative those viral particles are. So we may be, again, overshooting or overestimating how infectious or how much of a spreading these individuals do. But the current recommendations are that one would need to have 2 negative nasopharyngeal swabs. That's a deep sampling of the nose that goes all the way in the back of the throat. And there's a PCR reaction that then measures these viral particles. So after 2 negative, and they have to be about 48 hours apart, then that person is considered very unlikely to be spreading any virus. There's also a tincture of time. So for those who don't have testing available for these 2 consecutive tests, then the current data suggests that about 2 weeks out from the onset of symptoms, most people don't shed. But if you have been extremely ill, like on a ventilator, perhaps it may take a bit longer. So those are the words of wisdom currently. And again, a surgical mask on that person is advisable for that duration of time.
Peggy, you had a question that I forwarded you.
Yes, this is from John Craig Holland, and it says, your 4 principles make a lot of sense in theory, that's for philosophers, but in the chaos of an ER or an ICU, isn't the application of these principles a real challenge? And of course, Mr. Holland is absolutely right. In the chaos of an ICU or an ER, it is difficult to say, oh, well, there's this principle. But actually, I think the answer is these are things that we should have in mind all the time and ahead of time. So maintaining contact with a family. I was talking about what you should do for people who've been deprioritized in triage, but this would be true for any patient. And as Margot said, being blocked from seeing her family was one of the most difficult things. That doesn't have to be the case. Everybody comes into the ICU, presumably with a cell phone in their pocket, right? Or there can be things that a hospital rigs up. By realizing that contact with your loved ones is of not just some importance, it's of paramount importance to many people, right? That's not ancillary treatment. That's not, afterthought stuff. Sure, there's chaos in an ICU, but you can still do this, right?
There was a time when I started my training that newborns, after they were born, were put into the nursery where they were isolated for 24 hours so that medical and nursing staff could make sure they were okay and not be infected by their parents, who, for the most part, were going crazy. And pediatric services had 1 hour visitation. It was actually here at Colorado General Hospital and at Yale New Haven years ago that the chairs of pediatrics and OB got together and said, that's crazy, 24-hour visitation, and get the mothers and babies and fathers together as quickly as possible. I think we do have a lot of fear about infection. And at the same time, what are referred to as the social or behavioral parts of healthcare, along with the social determinants of health, are often set aside as being less important. I think we have some questions here around, will we ever get universal healthcare? I think until we find a way to merge the principles of public health, social welfare, physical health, and mental health into an integrated system that can balance that for everyone, we're not going to have universal health care.
We should remember that, having universal health care is not rocket science. Every other developed nation has it. We're the only ones, right? we could do this practically overnight if we had the political will to do it.
Absolutely. Absolutely. And we even have some low-income countries with healthcare, and also some Asian countries. Look at Taiwan, model country in Asia.
Right.
But I wanted to say, with a point what you had, Peggy, with the cell phone, because the power of the cell phone is so important. Because when I was admitted to the ER, I couldn't carry my own purse in.
Mm-hmm.
Oops, you muted yourself.
So until Margot comes live, I have some anecdotes from my colleagues who staff the ICU. So every patient has a cell phone. Nobody brings their charger. So if you remember to carry your charger when you go, hopefully don't have to, but you need that. And also, on a more serious note, many ICUs are receiving donations from wonderful people to be able to provide iPads to either patients, families, both. We're also having, not only here in Colorado, but throughout the country, the ICU community realized that with the surge, critical care physicians and nurses may not have the time that they used to have to inform these patients' families who are obviously very anxious to hear the news, and they grab on every word of hope or information that they can. But then when one has to carry, instead of 15 patients, 40 patients, etc., that time gets shrunk. So throughout the country, there are these link teams that they link families, they provide liaison services. They are physicians, critical care trained, they know what's happening. They get a quick sign out from their colleague, and then they do have the time, typically at home through telemedicine or phone, to call the loved ones and spend the adequate time to inform them of what's happening.
We have a question from the YouTube crowd. With many of us out of work and some getting virus requiring the most expensive care, shouldn't we separate medical coverage dependents from our employers? That circles around to the other question around, should there be universal health care, and how are we going to do that? I'll just ask if there's anyone on the panel who thinks that we shouldn't figure out how we should have universal health care. Okay, hearing none.
There are some easy ways to figure it out. One is take a multi-sided coin and flip it and copy any European system, for instance, or Asian system. Right.
You know what? I can say that that's true. And here, having spent a year working on the Senate Finance Committee, which oversaw Medicare and Medicaid many years ago, and having spent 50 years at a medical school and 25 years running a practice plan, there's no question we need to move to this. And it is also true in the American political system that when you are almost 20% of the gross domestic product, every single industry that we are seeing now come to play has got very effective lobbyists that are actually pushing their perspective, which isn't to go out of business.
Do you remember when Canada overnight nationalized its healthcare system?
Yep.
Yeah, the doctors went on strike.
Right.
And guess what happened? The death rate for the country went down. Yes.
All right. Well,
but there's another thing that we could do. This is a view of mine, and people laugh, but you might as well hear it. And that is, if you think about socialized medicine and how effective that can be, and ask where is the most effective socialized in that term healthcare system in the world? Is it the UK? Is it Canada? Is it France? It's right here in the US. It's the VA.
right.
Government doctors, government nurses, government everything. And when
First
it's
electronic medical record.
That's right. And if it were adequately funded still, you could open that to uninsured and underinsured and uninsured folks overnight. They're not all sick. And you could have and then you let people vote with their feet, you could have a radical transformation virtually overnight with nobody dislocated, right? Nobody loses, everybody gains. You think that's rocket science?
Nope. All right, this is the last question or comment. Well, somebody, same person asked if we should move to Canada. That's an individual choice. But this should point out how we need to develop better programs to support other sectors of people that are suffering, like domestic abuse, addicts, suicidal people, as they're greatly suffering at times like these. And perhaps universal healthcare can encapsulate programs like these. You know, what I would say is, particularly having spent only 40 years now working in the area of child abuse and neglect, that is I've noticed that this country doesn't support social issues very well. We support health issues fabulously. And so there is actually a not-for-profit organization for every organ of the body, every gene, every disease, adult and pediatric. They're all lobbying Congress, and they've pushed the National Institute of Health to $42 billion of research, and they've totally ignored things like abuse and neglect and violence, which in the family are the antecedents of a lot of the social determinants of health. But our time is running out. I say 3:26 on my watch. Maybe it's 3:24 on my clock. I want to give each of the panelists 30 seconds to say something that they wish that either the 160 people remaining on this thing had asked, or that I forgot to tell them. Let me start with Margot.
Start with Margot. Okay, well, you lost me there and now I'm in my bathroom because I need their power source. But the power of technology is what I was talking about, because it's so important. That's something with my generation that your generation, Richard, Dick, didn't have. Right. And that keeps us connected. And I couldn't carry my person to the ER, but I was lucky to have a nurse who went back to my husband and grabbed my cell phone for me so that I was not alone. And so just having somebody who treated me as a person and not just a patient was very remarkable. I really love that about the care that I received.
Okay, thank you. Irina.
Yes, I would like to leave with a message of hope. I am quite convinced that we will learn positive things from this crisis. And what I'm seeing is that the young generation of physicians and first responders, they have rallied, they are passionate, they took leadership roles, they really filled voids of leadership either due to illness or other causes, and they stepped up to the occasion. So to those of a certain generation who think that millennials may need additional TLC and additional guidance, our millennials impressed us quite a bit, and I'm so proud of how smart they are, how connected, they use technology to its best. We are gonna battle this, and our young smart folks are going to help do that.
Thank you. Shelly? Mute. Unmute.
Okay, I like to make sure to leave you with the idea that a healthy environment is essential, and that includes, you know, the air, the outside air of your community. If you have highly polluted air, it's probably because of fossil fuel use and too much traffic and combustion, and we need to demand, you know, healthy environments. And in your home, you need to pay attention to how to create a healthy home. Many people assume their homes are healthy and they are not. due to toxic building products and chemicals and the way the building has been put together. So, learning more about this and making sure that we all have access to a healthy environment is really key for me. And if you want to follow all of these topics, I tweet a lot, so you can follow me on Twitter.
Thanks, Shelly. Peggy, last word.
I'd like to echo the messages of hope, not only that this episode will conclude, but also that we will learn something both about our personal lives and our communal lives. But I think even more important is to start right now. Right now, thinking about the next epidemic. That's probably in 10 years, it might be in 50 years, it might be 100 years since we've had something like the 1918, 1919 flu. And it doesn't have to be a virus, it could be something else, it could be man-made. There's always the prospect of malicious use of viral science. But we need to be thinking now and never let our alertness down to what we could do better, what we can do better, what we can get ourselves to do better in advance. We can't forget.
Thanks very much. Well, panel, I want to thank all of you. I want to thank the 152 people who are still online with us. And this end of this session actually ends the week-long Colorado World, how could I forget the name of this?
World Affairs.
The World Affairs Conference on World Affairs.
Can I just say, I love that we were like an all-lady panel. Like that never happens. And we ended the conference. How awesome is that?
Yay, that's awesome.
And I need to let everyone know, now we're down to 145, that if you were listening, you're going to get a survey to let us know how we did and how this could be better next year. So thank you all very much. And we're going to be cut off.
And thank you, Dick.
Thank you.
Keeping us
nice
all
to meet all of you.
Under control. Right?
The pleasure wasn't all yours, as I'm fond of saying. I had a lot of fun.